Good morning. For those just joining, we'll wait just a couple of more minutes. There are a lot of people who seem to be bing bonging into the meeting. In the meantime, I'm dropping a link in the chat for all the home visiting supervisors and providers to complete. That's just like one of the questionnaires that we've had the beginning of the last two meetings, and so this will be our last one until the learning session, and then we'll review all of them. And as a reminder, if your name isn't showing up, if it has a phone number or something on as your screen name, this is how you can change it to the name we know so that we can tell who's here. This is our agenda for today. I think we'll go ahead and get started. It's 2 minutes after 9. I've dropped the link to the chat in the chat to this REDCap survey like we've done the last two meetings. I'm going to be mentioning it probably another time before the meeting's over to make sure all the home visitors and supervisors have a chance to complete this survey. And then we're going to hear from Kayla with some results on our referrals. David's going to introduce a couple of people who are going to present some qualitative data, and then I'm going to have a couple of things to talk about. So let me just drop this link one more time. You're going to get it one. I said one more, but I'll probably do it another after this one. But I liked the pictures that I found for my presentation because I feel like we got a little cheated on our fall colors this year. That they seem to go very quickly. I have a red maple in my front yard that turned red and dropped all of its leaves in less than a week. So, all right, let's go ahead and turn this over to Kayla. And Kayla, would you like to provide us an update on our referrals?
Absolutely. So good morning to everyone. Thank you for allowing me the opportunity to share with you, excuse me, this morning. And while I'm preparing to share my screen, I just want to say thank you to each of you. We have done some incredible work together. It's actually been about 3 months since we started this process as far as the Unite Us collaboration. And so I wanted to take some time to go over some of the highlights and accomplishments that we've experienced in those past 3 months. So on this slide, we're just talking about, it's kind of an overview of what we've done thus far. So one of our first goals was to build healthier communities, and we're doing that. We are equitably reducing barriers and improving outcomes and experiences for our clients, and we're improving efficiency and experience for home visiting agencies, and with the help of our referral network partners who include LASSO, PCAP, and Sooner Start. We successfully onboarded all of our home visiting agencies. Some of you were already on board prior to our work with the Innovation Grant. However, we have been able to create that Innovation Grant profile so that we can track the grant-related outcomes. As far as user adoption, 80 Innovation Grant users have been trained and added to the network. That number is going up because I know we have some trainings coming up for some new staff members who've been added to some of our home visiting agencies. And thus far, approximately 16 users have already sent referrals. Through the course of the work that we've done thus far, we have seen improvements in the volume as well as the quality of referrals that have been sent. And I'll talk a little bit more about that on the next slide. And then thanks to feedback from each of you, we were able to adjust our Sooner Start workflow process to increase referral acceptance, which was really a big win for us. And then finally, we continue to remain targeted in our focus on training and technical assistance in order to meet those SMART aims that were identified in the phase 1 part of this. And our leadership has been given access to our data delivery tools and insights so that we can all keep track of the data and make sure that we're headed in the right direction. So before I move on, does anybody have anything that they want to add to this slide? Any questions or comments? Okay, perfect. Well, I will move on to our highlights and accomplishments. So first was the custom forms configuration. And I really feel like this was a big win, not just for our efforts collaboratively, but throughout the Unite Us organization, because this was something that this is what we really want as far as working with the organizations that we work with. When we see something that needs to be fixed, then let's work it out together. So as you all will recall, we went live in August 2023. We had 5 custom forms, which was the ETO case number form, as well as the engagement mile markers. But then in September of 2023, LASSO identified a concern with the custom forms, which was that they weren't visible on referrals that had not been accepted, which was it was causing an issue, a bottleneck, because there's data that needed to be collected before referral was actually accepted. And so the powers that be, Lisa and David and Tabitha and their team, as well as myself, we put our heads together and we came up with a reconfiguration, which allowed us to move the custom forms to referral assessments, which now gives us access, as you all know, those of you who've utilized it. That means that users are able to get access to those custom forms for actually accepting the referral. So we did some additional training once we amended the custom forms process. We made some workflow adjustments as needed. And then we are at the place we are now where necessary data is being captured, including informations from referrals that are in needs action or are being held in review. Now that still doesn't encompass, just as a reminder, if a referral is rejected, we cannot capture that information, but as long as it's in needs action or being held in review, we can capture that. But again, that's just, that goes to show that you all are thought partners with us in this process, and that as you all remembered what I said very early on in the process, that we're building this airplane, this ship as we go forward. So we need to hear feedback and continue to move forward as necessary as thought partners in this process. And then finally, last slide, I just wanted to show total impact. So this is up to date as of 9 minutes ago. So right now we have 29 referred cases, and of those 29 referred cases, we're at 20 managed cases. That means that these are clients that the referrals have been accepted. They're actively working through the process of receiving the care that they need. Now, the big number over there at the end is 100% of cases have been managed or closed within 30 days. I want everybody who's sent a referral to give themselves a pat on the back, everybody who's worked on referrals to give themselves a pat on the back, because that is almost unheard of to remain at 100%, even 3 months out in a project of this caliber. That shows a commitment to making sure that people get their needs met, and it is really big. And we have received a lot of positive feedback from people internally at Unite Us who are tracking this and really cheering on the success of the innovation grant. So down at the bottom, on average, we have 1.8 referred cases per client. That means that of those 29 referred cases, that for several of them, they had multiple cases that were referred out on their behalf. And that's really what we want, because we know that with social determinants of health, usually if there's one issue, then there could be more than one issue. And so we want to make sure that we're addressing all those needs. 69% of referred cases have been converted to managed cases. And again, all that means is that we are working rapidly through those cases once they are referred, and we're moving them to being accepted, being managed, aka being bringing them through the process of working with Lasso or Sooner Start or whoever the case may be. At this time, 7 home visiting agencies have sent referrals. There is one agency that is leaps and bounds ahead of other agencies as far as sending referrals. But if you're a sports fan like I am, a lot of us are on the board, and that's what matters right now. So we're looking forward to seeing how things continue to progress. As always, and I know Lisa still has my calendar link. So if you have any questions, anything that you want to discuss as we're closing out 2023, I can't believe we're already there, but I know that there might still be some lingering questions. And if you have anything, please feel free to reach out to me by email or schedule a meeting on my calendar. And that is all I have. So I'm going to turn it back over to Lisa.
All right, thank you, Kayla. I've just dropped her link into the chat for setting up a meeting with her to ask questions or get additional training or guidance. We've had situations where something weird has happened with a referral, and Kayla's been so gracious to set up individual one-on-one meetings with home visitor who is trying to make that referral and has straightened it out. So thank you so much, Kayla, for being available to everyone. And I know that everyone really appreciates it and feels that you're very open to being approached. And that's really made a big difference. So thank you so much. Does anybody have any questions for Kayla? Okay. I'm going to drop the link again to the questionnaire that is available for all the home visitors and supervisors to complete. This is anonymous. It's like we've done the last 2 months. So if you have not complete, if you're a home visitor and you have not completed that little survey, then if you would go ahead and follow the link in the chat, I'd appreciate it. I'm going to drop it one more time. Somebody bing bonged in just like as I was dropping it in. Okay. David, are you on the phone?
Yes, I am. Can you hear me?
Yes. Yes. Would you like to, is there anything you'd like to talk about before you introduce Stormy and Olivia?
Well, just a precursor to this month's or this upcoming month of rounding calls. For the January learning session, we anticipate adding a little flavor to the normal presentations we do in the morning portion of the session. And we are going to circulate by email ahead of your rounding calls 2 examples from a past learning collaborative. I've mentioned this work previously with the tribal network of MIECHV awardees who worked on family engagement just a few years ago. And they had a slightly different style of presenting their findings from their PDSAs, and we're going to promote that alternative this round. So more information coming in your rounding calls. And prior to that, by email, we're going to circulate 2 examples that are on the web we'd like you to take a look at. Let's see. With that being said, I want to move on to the next item on the agenda, I think, which is a continuation of Results dissemination, we began in September, and two of our colleagues, Stormy Fuller and Olivia Lane, were with us and presented the findings from qualitative work on family engagement that has been done with WIC clients eligible for home visiting, but not yet participating in services. Part two of that work was qualitative interviews with providers. Some of you may be on the call today, and we wanted to update the whole group on what we heard from that side of the narrative. So, Stormy or Olivia, you're on. I'm going to pass the mic to you next.
Thanks, David. Good morning, guys. I do see some of y'all on here that I talked to for these results and for this project. So hopefully you guys will also especially enjoy seeing the results. And I want to thank you again for participating in collecting them. Okay, let me share my screen. Okay, these are MIECHV provider results. Like David mentioned, these will mirror the caregiver results that I talked about with Olivia a couple of months ago. So if some of it seems familiar, that's because it's kind of the partner guide. And this is setting us up for our third aim of MIECHV. So there will be some continuation of this as well. But for this round, we talked to 19 providers. About half were from parents as teachers, and then we had some Children's First and Safe Care rounding us out as well. Most of the participants were white and had a bachelor's or master's degree. We had, of course, quite a few nurses, and then some other people from psychology, early childhood development, early childhood education. We have providers who conduct visits in English and Spanish, and then our median age was 39 years old. So probably the demographics you all expected. Our aims for the study were to look at barriers and facilitators to enrollment in home visiting. And we used the MODS framework again in this guide, so I'll talk about that in a minute. We also wanted to ask providers about what they thought were appealing or off-putting components of their home visiting program for families who were eligible but haven't enrolled yet. And that MODS framework, we have taken this framework from HRSA, and it's actually a framework about states of engagement, but we are using it to reflect across the different states of engagement, and in this case, in enrollment. And so we're looking at how compatibility with the home visiting program, the caregiver's state of change in terms of parenting changes, and then also their own personal competence to make parenting changes, how all those things might affect their process or decision to enroll in a home visiting program. Okay, and then we can get into the good stuff, the data. So first, when we talked about increasing enrollment, what was really interesting to me was 38% of providers said that's not actually something that we really need to be focusing on right now. And for the most part, that answer came from not having all of the staffing positions filled for providers, or having them all filled and still being maxed out at capacity. This was especially true for Spanish-speaking agencies and needing more Spanish-speaking providers. For the providers who did have advice on increasing enrollment, the main one was to increase marketing, specifically on social media, and that talking about the type of incentives that the program provides, and then also changing the language from preventing child abuse to maybe promoting child well-being and family health. Changing that language a little bit to be more family friendly was also some advice that we got, which I thought was really insightful. We also heard from about a fourth of providers that letting families fill out enrollment forms online would probably be really helpful. Providers did have a couple areas that they thought that their home visiting program might not be compatible with some caregivers. And one that we've heard across several MIECHV projects, and we're actually looking into still in our current project, is this idea that sometimes the caregiver's needs from their personal life are trumping their need for parenting education, whether that's paying their bills, getting a job, domestic violence in the home. There's bigger things going on in their life than how they need to parent their child, and that can make it difficult. This reflects in what we also heard from about half of providers, that a lot of the times caregivers just have needs that the program doesn't meet. And about 70% of those could be met by outside services. Basically, they need other services. And I know both Olivia and I have heard from you guys before, and from the other providers, that sometimes you guys feel like you spend a lot of time doing case management duties and not so much getting to focus on the parenting curriculum that you'd like to. So seeing this data really tracks with that. It makes a lot of sense. And the other main thing that we heard in terms of incompatibility with caregivers was just that a lot of times they have things in the way in their life and they just don't have the capacity to participate right now. And of course, the main one for that was the work schedule of parents, 84%. On the flip side of that, asking about how we can improve compatibility, 27% of providers thought that providing financial support and just more tangible goods is something that the parents really need and would probably bring them into the program. What was interesting to me was that 44% providers talked about compatibility changes that actually had to do with providers themselves. A lot of this was increasing the number of Spanish-speaking providers and increasing diversity in general across the providers. We know that families do really well or do better with providers that they can personally identify with. We also had quite a few talk about the benefit of hiring providers that just work those evenings or weekend shifts, and then also giving some additional training for them. Moving on to the second step of the MODS framework, looking at state of change of our caregivers. 77% of providers said that in general, the caregivers can acknowledge what they need to change in terms of their parenting pretty accurately. And the areas that they do it most accurately and are most open to recognizing they need to change are areas that have to do with their child. Things like discipline and managing child behavior. And then, of course, things that have to do with child development. The caregivers feel comfortable and open to saying, yeah, that's probably something I need to change. We did hear that it's significantly more difficult for caregivers to talk about change in areas that they might not see directly affecting their child. Things like their own substance use or personal relationships that they have, maintaining good self-care, and also some of those parenting habits that they picked up from the way they were parented that have just kind of been passed down through the family. Those things that are less specific to the child, perhaps in their perception, are not as likely for them to want to change or acknowledge that they even need to change. Now, when caregivers have noticed areas that they need to change, providers say, 83% of providers say that most of the time they're willing to implement a new strategy to try to rectify what they see needs to be changing in their parenting. So almost all of them said that parents are pretty willing to try something new if they see a change that needs to be made. And effective ways to increase implementation of some new parenting strategy, of course, motivational interviewing. I know that you guys and the providers spend a lot of time learning about using motivational interviewing, and also educating the caregiver specifically on the benefits of making the change, and also to have realistic expectations for what they can expect if they try to implement something new. what I thought was interesting was over half of the providers said if they have a strong provider-caregiver relationship, that they're more likely to try to make a parenting change and to implement something new. So something about having that rapport and trust with each other encourages them to take your advice and maybe try something they wouldn't have otherwise. The last component of our MODS framework has to do with caregivers' confidence that they can make parenting changes that they want to make. And we asked providers, how can they tell if a caregiver has this confidence? And a lot of them talked about things that weren't super concrete. The term active engagement we're actually looking at in this next phase of our MIECHV active involvement in this next phase of our MIECHV project. It's quite a broad term, so I broke it down a little bit more specifically. The main factor was being self-motivated. Self-motivated included things like bringing up topics they wanted to talk about, being initiating things with the provider and with the child, following through on things outside of visits, practicing with their homework or their new skills, following through with referrals, things like that. A self-motivated caregiver showed that they felt they could actually change. Also, having a positive attitude and outlook was a really big part of that as well. Things like asking questions and having parent-child interaction were less surprising. Those are things that we've heard before, but I did think it was interesting and I enjoyed seeing these things that were more focused on the mindset and attitude of the caregiver. I thought that was some good insight. And then lastly, we wanted to ask about what aspects of the program might appeal or might be off-putting to caregivers who aren't enrolled. And these were less surprising than some of the other results that we got. Appealing aspects, of course, the connection to services and resources and providing tangible resources that the provider sometimes brings to the visits. And the child development information was the biggest one for sure. Things like nutrition, discipline comes up a lot. Parents really are looking for help on how to discipline their child. And then also pregnancy and childbirth information, which seemed to be kind of a comfort to the parents. And again, that supportive relationship with the provider was a big component. A lot of these caregivers, as I'm sure you know, don't have a lot of social support, and these programs can be a big source of that. And the main off-putting component that we heard, which we've heard before, is having the provider come into the home. There's always that fear that someone's involved with DHS or going to be judgmental because their home is messy. But I know that the providers put in a lot of intentional care into making sure that they know that they're not here to get them in trouble with DHS or to judge them, and they're really here to do the opposite. So as much as this might be off-putting at the beginning, from what I have heard from providers and caregivers, this isn't a long-standing issue once the visits get going and the report gets built. And there we go. Thanks so much. That's our data. Does anyone have any questions or comments? I'm interested in what you guys think.
Thank you, Stormy. Questions or comments for Stormy?
I just had a request. Are we able to get a copy of those slides?
Certainly. I can send them to
Great.
Lisa.
Thank you.
Yeah, if you would send them to Lisa Tunley, and when she distributes the recording for this session, she can also distribute these slides, and she can distribute my slides too.
Awesome.
Other questions or comments?
This is Yolanda. Program is Oklahoma City Public Schools, parents and teachers, but one of the things that kind of got my attention is the relationship, because we know that the provider has with the families. And also, that's why sometimes, and I say, well, I would say most of the time happens when the provider, for some reason, is no longer with us. We lose the families as well. So that's one of the things that the downside about that. It's good that they had that relationship built with the provider, but again, we lose families in that way as well when we lose providers.
That's interesting, Yolanda. That makes sense though, looking at the data. Thank you.
Susan, I see you talking, but it's not coming through. It's making this odd mechanical sound.
Now you're muted, Lisa, but
Oh, are
yeah,
you
you're
going to put it in the
redistancing.
chat, Susan? Are you going to put it in the chat? Okay.
I was curious about the commentary on evening and weekend staff that specifically focus on that. Is there, Lisa or Dr. Bard, is there any research or data on programs doing that currently across the country?
I yield to David on that question.
Yeah, not that I'm aware of. I mean, all programs that I've spoken to seem to allow that as some flexibility for the clients. But you know, we've heard from you all, and I've heard elsewhere that you know, putting that in your guidelines and then putting it to practical use are sort of two separate issues, and that it's been a challenge to offer visits in the evenings and certainly on the weekends and maintain your staff. So
Yeah, I would agree with that. And it just the timeline of getting documentation turned in within a 24-hour period, then that cuts further into your weekend or evening time, and it kind of creates more burnout in the long run. So yeah, it's definitely an issue. I found that interesting that might be something to consider, that dedicated staff just for weekend and evenings. And I know they're out there because they can't work Monday through Friday during the day for whatever reason. So, or it just appeals to them to do the weekend and evening. Thanks.
yeah, no, and I'm glad you brought that up, Kathy. So that's definitely going to be one of the takeaways we highlight from this work. And we not only heard it from the providers, we heard it from the clients too. So there clearly seems to be a need for evening and weekend visits. And I think programs and really model developers are going to have to be creative in how they attempt to adapt to meet that need.
Yeah, it made me think of the father engagement data too, David. And when Stormy mentioned having staff dedicated that, I was like, ooh, never thought of that. But and maybe looking at the medical field and having like that shift differential, the extra pay that you provide for the after hours and weekend hours to make it more appealing. You know, and just thinking about parents that, you know, this probably would be a good fit for some families, that they need to be home 8 to 5 or whatever, but then they need a little more income to supplement. So really digging into that sounds interesting. I know previously on using the same staff, it gets to be really kind of difficult with that shifting it out. It only leaves very little time. So if someone's doing 8 to 5 and they take on a client, then they're going to shift it, and are they, 10 to 6, and there's only so many limited slots. So yes, this will be interesting to see as it rolls out. I know I'll forget about it, but as you hear stuff, David, and this is a long-term thing, keep us up to date on that. Very encouraging.
We used to do a lot more evening and even Saturday home visit. For some reason, they did not end up working. I mean, the families, maybe that would work also on a Saturday, but maybe if he didn't, they have so many errands and things to do that the workers were hanging, like, I went there, I was gonna do the home visit, I don't have a home visit, so am I gonna be paid or not? I mean, it was just, it was a little difficult that we stopped doing it. It did not work for us to do the weekend home visits. But it'll be interesting. I was late for your presentation, Stormy, so I'm glad that you're gonna be able to send it. But the last piece that I was able to see, I thought it was very interesting that they said that they liked more of this relationship they were building with the provider, and not necessarily all these resources that we're giving them, which I thought it was interesting. You know, you would think that maybe they're there for all the, you know, the diapers and wipes and all these things that maybe you give them. But at the same time, I don't know if I got it correctly, but at the bottom, it was like having them in the home. So how do you build a relationship if they were saying we don't want them at home? I mean, that was interesting. What can you tell us about that? I mean, how did that came about, that comment?
Well, these were the provider perceptions, but we've heard similar things certainly from caregivers over the years that they do feel, well, first of all, I think the biggest one is they have a perception that home visiting is somehow related to DHS, and that the provider is going to come into their home and be looking for things and be making sure that they don't need to take their kid away, and like maybe they will, and maybe I think they just have a lot of fear about that. And then also a lot of the families are living in a space that might not be big enough for them. It might be cluttered, it might be messy, they might not have utilities on, different things that I think sometimes they just feel a little bit embarrassed about being judged for. And that's, yeah, those are the main things that we've heard from the providers and from the caregivers.
Okay, thank you.
I'm seeing some comments in the chat. Susan said she was surprised at how high the percentage was for home visitors coming into the home, and what she was wondering how to overcome the negative perceptions, and that in C1, or the Nurse Family Partnership, they've been trying by offering the visits with the nurse anywhere that the client was comfortable, and then eventually going to home visits, and that they're not marketing that it's home visits. And so I think that's a good point. Lena added that the evening and weekend visits that she tried never worked out, that there were always cancellations and no-shows. Other feedback, comments, questions?
Yeah, we also have some, well, we did during the pandemic, yes, we have some evenings. I remember one of the parent educators that were doing at 8 o'clock because the husband wanted to be participating, which it was a good thing. But evenings, it didn't work for us. And Saturday, I think we tried with a couple of families, and like Patty was saying, the families just cannot commit it because, I mean, they get so, you know, busy, dinner time. And also another consideration that I always, when I have parent educators doing late visits, especially in the winter time, is safety. So, I mean, when I have a parent educator that, you know, maybe doing a visit at 7 o'clock or 6 o'clock and it's already dark, you know, I was like, well, please just text me when you get off, you know, your visit, because I just want to make sure that you're safe. So that is a few things to keep in consideration about that.
Definitely.
Yeah, that's a good point.
It's interesting to me from the ones of y'all who have tried it, that it hasn't worked very well, because I feel like in most years that we talk to families, that's something they mention. It's interesting to me that there's this discrepancy between what they think might be helpful for them and what they actually end up utilizing well in the services.
Yeah, they may be, when you're asking them, what can we do? They're imagining, well, you know, maybe a weekend visit, but it's not applied to their particular situation. They're thinking, for somebody, this might be really helpful, but for them, it ends up not being. But, you know, it's easy to see. You're used to thinking of meetings as being during the week. I'm seeing more comments in the chat that that's the experience of people canceling on nights and weekends. So. Any other comments, questions, feedback?
the need for Spanish speaking providers. Seemed like every space I'm in. I was just in a health department meeting yesterday and they were talking about the same thing. Need more Spanish speaking providers. And probably further than that is providers that know the culture. So
Yeah,
that's
that's a good point, because someone can take Spanish lessons and learn to speak some Spanish, but that's not the same thing as being part of the culture and understanding and being able to offer that connection.
You know, Lisa, too, every semester we receive bachelor prepared nurses, and my thinking is most of these kids get exposed to Spanish in school now, but we're not seeing that flow into fluent speakers, just conversational fluent Spanish. So that's been a little bit of a step back for me. I just made an assumption that all these kids are going to be, we don't need them to be medically fluent in Spanish, but just conversational, and it's just not there. And certainly out in the marketplace, we're finding it very difficult to find bilingual RNs. I guess we all need to move to Texas because that's where a lot of them are.
Yeah, and I don't think that I think that this need's only going to grow, and it takes a lot to become fluent in any language. I
Sure.
studied French for 7 years and I got close, but I'm, not fluent. Certainly not after so many years of not using it. All right, this is very good. We appreciate you, Stormy, for presenting these results. Kudos to you and your team. Thank you so much.
Thanks for letting me present, and big shout out to Olivia and Amy for all their help with the interviews.
All right. David, is there anything you'd like to talk about?
Stormy had already mentioned it, but we're well into the next phase of that portion of the evaluation. We're shifting our focus away from initial engagement to what we're calling active engagement, or what others have called active engagement. So looking at clients who've been a part of your program, those that you're able to retain long-term versus those that you lose typically early on. So similar types of questions, slightly different population, and as soon as we have those results, we'll be happy to share those back with you in a future monthly call. Oh, the other plug I'll give is that the data that you just saw, we're mentioning on a panel that is scheduled for the all grantee meeting end of January. And so any feedback we get from the broader community of home visitors throughout the US, we'll be sure to relay back to you at a monthly call early 2024. And maybe we'll even see some of you there. I'll be at the all grantee meeting and the summit that follows. So,
David, would you like to share the link to those presentations that you referenced when you were on the phone?
yeah, I will do that now, and then we'll have Lisa include that in the email that she circulates.
Yeah, I forwarded the link to her so that she can include it in the email following this meeting.
Perfect.
Were you going to do that now? I mean, were you going to show those presentations? Okay.
I'm sorry. No, I was not going to share them now.
Oh, okay.
To be honest with you, they're a little lengthy. So one of the things you're going to hear in the rounding call is we like the idea, and we definitely want to give you a little more creative license on how you present back results, and we anticipate a lot of what you'll present in January, because we're still sort of early in this process of using Unite Us, will be the so-called recipe, the do steps, right? So you tell us what's working well, what's not, how have you had to adapt the process. We anticipate the majority of your discussion will be on those topics. So these are just meant to be examples. They're definitely more lengthy than what we anticipate seeing at the end of January. So it'll be typical length. We're looking for 15 minutes with some Q&A built in. So keep that in mind as you look at the examples that we circulate.
And we're hopeful that we can get you some data sometime soon, by the end of the year for sure. We have just heard this week that the connection's being made for the secure transfer of the data from Unitas to OU. And so then we can process the data. Andrew will be graciously taking care of that huge task for us, getting it into a format that we can analyze, and then those of us who are creating dashboards for you can get something to you. So that'll take some time for us to do that analysis. So progress is being made even if you don't see it. So let me share my screen, and can you see my presentation?
Yes.
Okay, thank you. We had a discussion come up in another meeting where we were talking about how referrals sometimes don't go right, and they between organizations, and we came up with this graphic that I'd like to show you, because I think all of you have two organizations within Unitas: an innovation grant organization, and then an organization that's not affiliated with the innovation grant. So in this column, this is just an example. I'm not picking on the Tulsa Health Department. This is just one that I chose because I had a particular referral in mind. And I'm not picking on Lasso as the referral partner. That was just the example that I had in mind. So Tulsa Health Department has two organizations, and within the innovation grant Tulsa Health Department organization, that's what our Tulsa C1 partners use. But there are, the Tulsa Health Department has other programs that they're referring from their non-grant organization. The same is true for Lasso. For this project, they're referring from their innovation grant organization, but then within Unitas, they also have a non-grant organization. So when Tulsa C1 wants to refer a MIECHV client to Lasso, then it goes from innovation grant to innovation grant organization. Great. If it goes the other way, if Lasso has one to refer back to C1 for help on specific things, great. Innovation grant organization to innovation grant organization. Then if some other program in like Connect First, which is not C1, in the Tulsa Health Department wants to refer someone to Lasso, then they would go from non-grant organization to non-grant organization. Great, perfect. And the same is true if Lasso has a client that's not in home visiting, but they have other services that the Tulsa Health Department could help with, then they can make a referral from their non-grant organization to Tulsa Health Department's non-grant organization. The problem happens is when we cross from a non-grant to a grant organization or vice versa. That's where things get turned sideways. So we don't want to see from a non-grant organization to a grant organization in either direction. So I hope that helps clarify a little bit some of the concerns that have come up. Any questions about that? Okay, David has dropped in the chat this web page that's promoting some learning collaboratives for tribe from our tribal partners. And at the bottom of the page, you'll see two PDSA examples. Oh, Tabitha's pointing out that innovation grant will be in the organization title if it's the innovation grant organization. All right. So today's REDCap survey. True or false, anyone can refer a child to Sooner Start for developmental testing and intervention. That's true. True or false, Lasso conducts an intake interview before determining if they can take a case. That's true. During the MIECHV Innovation Project, Lasso will accept referrals from your clients without regard to their age, income, or jurisdiction. But outside of the innovation study, Lasso does have some limitations. And so here are some statements, and which of these are true? Well, the first and the last ones are the ones that are true. If it's not part of the innovation grant, then they're going to prioritize their older clients. And they may deny services to people with certain income levels, that they want to help the vulnerable who don't have that they don't have those resources. David, could you address the error that Lena came up with when she tried to follow the link? True or false, referral assessments is another term for the custom form that referral partners will use to report the engagement mile markers and update the process of contacting and engaging clients who've been referred. That is true. You know, we've been calling them custom forms, but we had to move them from custom forms in order to be able to be accessed before the referral was accepted. Let me follow David's link and see if I can get you a link that works.
Okay, I think I figured it out. So my apologies.
got
That
it.
was in an email, and our
I got
university encrypts that link. So I've given you the unencrypted website in the
Oh,
second.
okay. We both have then. All right. Which of these home visiting clients would be good candidates to refer for PCAP? Well, Sylvia is in an intensive outpatient substance use treatment facility, and her son is in DHS custody. She hasn't lost her parental rights, though, and it's okay that she's in an outpatient program. She would be a good candidate. Marion has co-occurring diagnoses. That's okay. Her child showed withdrawal from Suboxone at birth and is currently in the NICU. That's okay. She has a child under 2 years old. She has the fact that the baby is withdrawing from Suboxone, which is a drug used to help people who, Tabitha, could you jump in here and say, is it for meth addiction? Or is
It's
it
for opioid addiction.
opioid addiction? Thank you.
Thank you, Katie. You're welcome.
All right. So she would be a good candidate. Christina is 30 and has a 12-year-old son diagnosed with fetal alcohol syndrome. She has an IUD implanted after the birth of her youngest son, age 3. Now, at first glance, you would think she's not a good candidate because her children are over 2, or that she's got an IUD, but that's a removable form of birth control. So she's still in the years of childbearing, and she has a son with fetal alcohol syndrome. So she would be a good candidate. The ones who wouldn't be good candidates to refer. Jennifer has a 3-year-old daughter who receives services for developmental delays related to her abuse of Prozac during pregnancy. The daughter is older than 2, so she wouldn't qualify. But you know, if you have a doubt, you can always make a referral and let PCAP make that determination. Melissa's parental rights of her 16-month-old son have been terminated due to her substance use. She does not have a child anymore legally under 2 years old, so she would not qualify. Which of the following professionals or services working for Sooner Start may provide services to a child with developmental delay? Well, that's all of them except physician and court-appointed advocate. So all of these professionals or services can be available for your clients through Sooner Start. Here's two items that are true false, the last two. PCAP will work with cases with DHS involvement and mothers with at-risk alcohol use who do not currently have custody of their children under 2 years of age. And then there's a question about the button in Unitas labeled add new form submission is used only to create a new form. The first one's true, the second one's false. PCAP will work with mothers with DHS involvement and mothers with at-risk alcohol abuse who do not have current custody of their children within the age group. But they have, as long as they still have their parental rights, the child may have been taken temporarily out of their custody, but they still have rights. And the button labeled add new form submission, it's adding something to a form that's been submitted. So the first time you click it, it's creating a form, but after that, it's adding to the form. So it's a little bit of a confusing term. Any questions or comments about any of those survey questions? All right, David, is there anything else you'd like to say before we wrap up?
I think that covers it.
All right. Thanks, everybody. We sure appreciate your time. Have a good day.
Yes.